And good morning to our guests this morning. Just in relation to the individual health identifier, obviously this was widely used to a certain degree during the pandemic. But since kind of the pandemic, how much of this kind of, I suppose, use of identifier is used now in everyday kind of health settings?
So it's beginning to be used, Deputy, right, in healthcare settings. The biggest challenge that we've had with the individual health identifier wasn't the overall index itself. It was the population of that index into individual solutions, because part of the challenge is to make sure that we absolutely uniquely identify the person before we assign an IHI to them. And as I was saying, so we've started with some of our really big solutions. We're rolling that out at the moment to our patient administration systems, starting we started in the northwest and are working our way down the country. So we are about, at the moment, say in Letterkenny Hospital, we're about 36% of the way there, Sailta 58% of the way there, Dublin Midlands Hospital Group 72%, and D&E about 75%. And we've also rolled it out into other areas as well, PCRS, health screening, the COVID, as we spoke about, GP practices, okay, and any message that goes across our HealthLink bus. And we send about 30 million messages across our HealthLink bus, and that allows us to communicate between primary care GPs and our acute hospital. We then also will take those messages and put the IHI into those messages as well. So we are rolling the IHI quite considerably. In addition to that, then we utilise the IHI within our data lake, where we're bringing data together so we can aggregate that data and try and get views of patients across the totality of the solution stack.
And how long do you think it will take to roll out that this programme itself?
So we would hope to be in a position where, by the end of this year, okay, there'll always be new systems and there'll always be things that will need the IHI. The rationale of rolling it into the patient administration systems in the hospitals is because the patient administration systems are the front door to a hospital, okay? And from there, they spread that data to other systems. So all the other clinical systems would then have the IHI as well. So our goal really is this year to really establish the IHI as the primary utilisation. Now, I know within the Health Information Bill that I'm aware that that one of the asks is in that is that the IHI and the PPSN would be utilised, okay? And because of the way we've configured the solution, okay, we can make that swap very simply as well.
Okay. My next question is obviously on the substantial issue of how in kind of a hospital setting, how much is Irish hospitals digitised or in relation to paper-based? And I'm pretty taken aback by the answer. According to Professor Martin Corley of Maynooth University, he reckons that 85% of all Irish hospitals remain paper-based. Is that correct?
So there are substantial point solutions in our Irish hospitals, right? So, if you look at all of our laboratories are digitised, our patient administration systems are digitised, our radiology systems are fully digitised, okay? And they do account for a huge amount of the traffic within that. There are also many point clinical solutions, but the core medical record is not digitised, okay? Except for in the areas where we have deployed electronic healthcare records, i.e. the James's and the 4 maternities that we've spoken about.
So he's correct by saying that 85%.
I think that would be a bit high. Would be my own assessment. Brendan, but you might have a.
It's in terms of the core documentation is predominantly paper-based.
Yeah, paper-based.
In the absence of
it's definitely north of 50%. He says 85%, so in between.
I would think so.
And obviously that's going to take a long time before that's, I suppose, changed over to digitisation. That will take a considerable amount of time, I presume.
It's not simple. Even in the 4 sites in the maternity or in St James's, the implementation I would say changing to an electronic health record has been one of the biggest changes in my professional working life in terms of, because it impacts on each and every way that we work. and work right across the healthcare team with vast advantages and improvements, but a heavy investment in time, and not just money, but time and resources and training to ensure that that's done carefully and indeed continued and optimized even after the solution goes in. The solution is a combination of people and process as well as the technology.
Yeah, and obviously this can be done.
Oh,
You've seen other jurisdictions where, you know,
we are doing it.
Yeah, we are doing it. Obviously, we're way behind, and I suppose, you know, considering Ireland has all these IT companies.
I would say that, again, even in there are well-recognised international examples of where this has been done and failed. I keep coming back in my mind as the clinician here at the table as being that this is clinical projects that are digitally enabled, and really it needs to be from the front line, the end users, because otherwise it'll be an expensive piece of kit that's left. I've been in ivory tower academic centres in the United States where the residents had their backs to the computers, still with their paper in their hand, in some of what were meant to be the ivory towers and the best centres, whereas to be successful, we need to engage from the ground up the clinician team so that they see that it's for the benefit of, I mean, most of us go to work for the benefit of the patient first and foremost, and they see that this is a patient care and patient safety issue that then also makes their healthcare provision more efficient and easier. So in some ways, to take time and give time back to the care.
Yeah. And Dr. Murphy, there's obviously kind of huge advantages in relation to efficiency, in relation to digitization, but there's also possible pitfalls.
Indeed.
I mean, obviously in everything that
Indeed.
we do. But what pitfalls?
Well, I think, I mean, I can again just give you examples of our own, and this is why there were questions about downtime and unexpected attacks. One has to build in contingency. Healthcare, it's almost like trying to put in place a new solution when the plane is still, or the train is still careering down the track. So we have to put in place solutions that work for the end user, but at the same time are safe and effective, with backup plans, contingency plans for business as usual, for downtimes, and we try and mitigate the risk. I happen to be the clinical risk manager as well as the clinical lead neonatologist for the maternity and newborn, and we have to put in risk mitigation to try and reduce the risk of harm, and we try and foresee the known unknowns, but to paraphrase another committee member in the United States, it's the unknown unknowns as well. And to try, none of us ever envisaged a complete cyber attack on our complete healthcare system, and yet we had it in place, even in that awful time, the beginnings of a 24/7, where we could at least get the immediate information available to hand to continue to provide care, while it took us several weeks to recover and build back up our systems, and to try and mitigate the risk for the patients at the bedside.
I think, Deputy, if I can just add one point, if that's all right.
Yeah,
so, I mean, you know, there have been well-documented international challenges and disasters, if it were that way, with electronic healthcare records. The reason why ours have been successful is we've taken some of the lessons that we've learned there, and a lot of that is around having a really strong clinical lead and clinical leadership, okay, from the very beginning of the programme. Having, you know, making sure that the team, the HR team, has got clinical specialists from all sorts of areas on it, you know, nursing, other specialties within the hospital, okay, and having them design, validate, test, okay, and deliver with their colleagues the solution set. And as Brendan said, the IT people then really are an enabler for that, and making sure that it happens successfully. But ultimately, clinically, these are clinically led, clinically delivered programs of work. And they're the ones that have been successful. And we can see it even on our tactical solutions that we've deployed, where we have that clinical leadership, clinical guidance, oversight. They're the ones that are successful, and they don't end up being, you know, a piece of tin sitting in the corner.
Just in relation to this wonderful technology that we have, and you know, it's a wonderful thing, but in relation to patient confidentiality and patient, I suppose, input and seeing their medical records, is this a kind of a game changer in relation to the digitization of medical records? Because obviously, you know, that what still goes on, it's basically kind of paper-based and so forth. But now, most of your medical records now can be done in real time, not only for the doctor or the nurse, but also the patient. How like, does this kind of change the dynamic of this kind of relationship between doctor and patient and so forth in relation to digitization?
I think both in primary care and in the acute setting, and this is where some systems have failed, because the system needs to be designed so that the doctor isn't just the doctor, I say the doctor or the healthcare professional isn't spending all their time at the computer instead of with the patient. And that's certainly been a criticism in North America, I'm sure. We've all read that. But what we've tried to do is to design systems that enable real-time documentation. I can give the example in the neonatal intensive care, where nursing staff are documenting and using the systems to take the measurements from the monitors and the ventilators in real time and validating them, as opposed to having to manually transcribe, so that the data is probably more accurate, more structured for interrogation later, but it also takes time away from manual transcription for the nursing staff. We worked out that nursing staff were saving in the region of 45 minutes per shift, which translates over time. But more strongly than that, our nursing staff love it because it frees them up to both deal with their patient at the bedside, and also they get home on time. They're not spending an hour at the end of their shift retrospectively writing notes. 45 minutes per shift per patient or thereabouts, just in that example. So it's I think the strongest example of that, to not hog the chair, is to say that our junior medical staff who move and rotate between hospitals, and now I can say this for myself, where I've moved for other reasons to University Hospital Waterford, where we're paper-based, we missed the electronic record. When it went down, from people who really had an aversion to using the computer at the outset and needed to be coaxed and changed. And every project there's early innovators and laggards. Even those people were going, I never thought I'd say this, but, you know, because of the efficiency and the freedom and the access. It's not perfect. We still need to optimize it. It's a living system that still has input. But even then, with a national system with careful governance, we take the ideas in and try and assess them to try and ensure that my good idea doesn't impact elsewhere and mitigate risk. But it's working well.
Thank you very much.